Okay, so today what we're going to have a think about is potassium homeostasis. And I've kind of titled it from cellular physiology to clinical interpretation. But the reality is what we're going to do is we're going to think about how potassium is regulated and what its main functions are. And then we're going to talk about hypokalaemia. And in a session after this, we'll go through hyperkalemia. So look at this one first because you get the potassium homeostasis, then go on to the next one, which is hyperkalemia. Key things to remember: potassium is the major intracellular cation. And even though only a small proportion is at present extracellularly, so about 2% of the total potassium is outside the cells with 98% inside, that plasma potassium must be tightly controlled because it directly affects nerve, skeletal muscle, and cardiac function. And so what this session is doing, it's moving from that normal potassium distribution and regulation to some interpretations and thinking about what causes low potassium results, or what causes hypokalemia. So first, we're going to start with a little bit of a review question. So just to kind of put things into context for you. So I'd like you to read this question and try and answer each of the three little questions below it. So press pause. A 60-year-old woman with stage 4 chronic kidney disease presents to the emergency department with generalized weakness, palpitations, and muscle cramps. An ECG is performed, and that is shown below. So the first question, what does that ECG show? Well, hopefully you can nice and clearly see the nice P waves, the QRS, and here is your T wave. So what does that T wave look like? Well, it's tall, it's narrow, and it's symmetrical. So you've got tall, narrow, peaked T waves. Okay, which biochemical abnormality is most likely? Well, what normally would can likely cause these peaked T waves? Well, that is hyperkalemia, so increased potassium in the blood. And why is this patient at particular increased risk? Well, they obviously have chronic kidney disease, stage 4, so there is reduced renal potassium excretion due to this advanced CKD, and that increases the risk of potassium accumulation and subsequent cardiac arrhythmias. So we're going to go into potassium homeostasis now. So like I've already said, 98% of the potassium that is in the body is within the cells, and about 2% remains outside the cells. And that level is around about 4 millimoles per liter, to put it into context of kind of remembering where that is. The important point isn't that actually potassium is mainly inside cells. It's actually that the steep concentration gradient across that cell membrane between the intracellular and the extracellular helps to establish the resting membrane potential of cells. And really importantly, because the extracellular pool is so small, so only 2% remember, movement of a relatively small amount of potassium in or out of cells can massively alter the plasma result without necessarily altering the total body potassium levels. And that's an important thing to remember. If you're thinking about hypo or hyperkalemia, does total body potassium also change? What's maintaining that gradient? Well, you'll probably know that potassium gradient and how it's maintained. It's done through the sodium-potassium ATPase, which moves 3 sodium ions out of the cell and 2 potassium ions into the cell. So here's a little table for you to have a think about, and it's really some of the functions of potassium are shown on the left-hand side. So resting membrane potential, action potentials, muscle function, cell volume, acid-base interactions. And on the right is there's the kind of, why does it really matter? Now you can press pause, have a little bit of a think about why each of those matters, but I will go through them straight away. So I'll give you 2 seconds for pausing. Bing, bing, 2 seconds done. So resting membrane potential. Well, obviously that resting membrane potential is important because it determines the excitability of both nerve and muscle cells. And in terms of action potential generation, of course, potassium is involved in supporting electrical signaling and repolarization after an action potential. Muscle function, we know, is essential for skeletal, smooth, and cardiac muscle activity. And as 98% of the potassium is inside the cells, and it's at about 140 millimoles per liter inside the cells, it's that major intercellular cation, so it contributes to that intracellular osmolality, or concentration of everything within that cell. So remember, osmolarity of your blood and of your cells themselves is about 290 milliosmoles per liter. And potassium inside the cells makes up about 140 of that. So it makes up about half of the total osmolarity that's within your cells. It's also important with acid-base interactions because you get with potassium levels changing and with hydrogen levels changing, either one or the other can shift in and out of cells to try and compensate for the other ones. And we'll talk about that in a little bit. So if you have an acidosis, for example, hydrogen ions will start to shift into the cells, and to maintain that resting membrane potential, potassium ions will shift out, and vice versa. So a key thing, 2% of body potassium is extracellular, so about 4 millimoles per liter, so quite a small amount. And plasma potassium is normally maintained within a very narrow range for obvious health benefits. So what are the mechanisms that affect cellular potassium uptake and loss? Well, there's a little diagram helping you there. So using that diagram, I want you to think what's going to drive potassium into the cells, what's going to drive potassium out of the cells, and kind of think about what might happen in disease states when you're thinking about that as well. So press pause, the diagram's there, so it's helping you. What's happening? So just looking at this little diagram on the left-hand side, so it's showing you that these three situations can lead to potassium coming into the cell. So insulin drives potassium uptake into cells. Epinephrine or adrenaline, so β₂-adrenergic stimulation, that drives potassium uptake into cells. And then you've got alkalosis. So alkalosis will also drive it. So I want you to think about what's happening in an alkalosis. In an alkalosis, the extracellular fluid around here doesn't have enough hydrogen ions. So hydrogen ions leave the cells, and to replace that, potassium ions go in. Okay, so that's what's kind of happening there. And then you've got, on the other side, you've got the opposite. So exercise and cell lysis. So exercise causes potassium to leave the cell. Cell lysis, when they break, they release their contents. Hyperosmolality, so too much concentration will allow potassium to be efflux. And an acidosis will, in exactly the same way. So an acidosis, too many hydrogen ions in the extracellular fluid here, they come in where they can get buffered against the proteins within the cells, and potassium ions come out. So you've got all of those kind of balances going on all of the time within the body. So I want you now, a couple of questions for you to think about. So what causes of cell lysis can you think of? So that's where the cells break. And what is a likely consequence of insulin deficiency on potassium homeostasis? So press pause and have a little bit of a think in each case. So cell lysis, what can you think of? What are some of the kind of the common causes you might think of? You might be thinking about hemolysis, so the breaking or damaging of red blood cells. Okay, so they have a shortened lifespan. So that leads to hemolysis and leads to the release of potassium from cells because there are a lot of red blood cells. Rhabdomyolysis, the damage to your skeletal muscle cells, and those skeletal muscle cells then go on and release that potassium into the blood. Other things are also released during rhabdomyolysis, just so it's in your head. So you've got myoglobulin that is also released, and that's quite damaging to the kidneys. So that's myoglobin is the oxygen storage molecule in your skeletal muscle. And then you've got tumor lysis. So tumor lysis syndrome, if you've got a tumor and you get a rapid damage or killing of those cells, those tumor cells, that releases a lot of potassium into the circulation as well. Likely consequence of insulin deficiency on potassium homeostasis? Well, you can just look up at that image. Insulin drives potassium uptake into cells. So an insulin deficiency will shift potassium out of cells, leading to a potential hypokalaemia. So that was the internal potassium balance. We also have to think about the external potassium balance. So again, I want you to press pause and I want you to think which hormone primarily regulates plasma potassium levels, and it does this via the kidneys. So when you thought of that hormone, what other things does it do? So what's it do to potassium, first of all, in the kidneys, and what other things does it do? Press pause. Okay, so if you don't know, the hormone that I'm hoping that you're thinking of is aldosterone. Okay, so now what is the driver for aldosterone release? Well, aldosterone is driven by the release of, or is driven by the renin-angiotensin-aldosterone system. Remember, that is part of the low blood pressure circulation, or it's the renin-angiotensin-aldosterone system, sorry, just kind of regulates your blood pressure longer term. So if your blood pressure drops, renin is released. You stimulate the renin-angiotensin-aldosterone system. Aldosterone then goes on to drive sodium reabsorption. Water follows that sodium, and that increases your blood volume and blood pressure. And it does all of this in the distal nephrons, so in the distal tubules and in the collecting ducts. But as well as being released in response to the renin-angiotensin-aldosterone system, on its own, an increased plasma potassium will also stimulate aldosterone release. Why? Because aldosterone also, in those distal nephrons, increases potassium secretion. So it's a mechanism for removing too much potassium from our circulation. And at the same time as releasing potassium, it also promotes hydrogen ion excretion. So it does a couple of things there. So again, we get you to have a little bit of a think. What are the likely consequences of primary hyperaldosteronism on electrolyte balance? So I want you to think about all the electrolytes, not just potassium, and primary hyperaldosteronism, for example, Conn syndrome, okay, is the other name for primary hyperaldosteronism. And what are the likely consequences in the second question of primary adrenal insufficiency on electrolytes balance? So you might be thinking about Addison's disease with that one. So again, press pause, have a think about what will happen. And I want you to be thinking about sodium. I want you to be thinking about hydrogen and potassium and blood volume, obviously, as well. Okay, so likely consequences of too much aldosterone. So potassium secreted. Okay, so you've got lots of aldosterone, so you're secreting lots of potassium, leading to potentially hypokalaemia. You also secrete hydrogen ions, leading to a metabolic alkalosis. Sodium, of course, you're reabsorbing that. That sodium's reabsorbed. Water follows it osmotically. That increases your blood volume, and that therefore leads to hypertension. So there's your primary hyperaldosteronism, or Conn's disease, or Conn syndrome. Primary adrenal insufficiency, we're thinking Addison's. Really the opposite. Potassium is now retained. You can't excrete it as effectively, so you're more susceptible to hyperkalemia. Ditto, hydrogen may be retained, so a tendency towards a metabolic acidosis. And sodium's excreted, water follows, so you're more susceptible to hypotension. Remembering, of course, that in primary adrenal insufficiency, this is also where cortisol is made. So there will be a lack of cortisol in this condition, and that can lead to hypoglycemia. That isn't a focus of this session, but it is important for you to remember that in primary adrenal insufficiency, you are getting a lack of both aldosterone and cortisol. Okay, so we're now going to think about the main causes of hypokalemia. So we're really I want you to think about it into three practical questions. Is potassium intake reduced? Okay, and in itself, poor intake is rarely sufficient to cause hypokalemia. Is potassium being lost from the body is the other question. And the final one I want you to think about is potassium moving into cells. So are we not getting enough intake? Is it being lost from the body, or is it moving away and into the cells so it's no longer in our plasma where we're measuring it? So like I say, decreased intake, nice easy mechanism. That might be a poor dietary intake. Then we're thinking about GI loss. So we're losing potassium through the GI system. So we're thinking, is potassium intake reduced? We talked about that. Is potassium being lost from the body? Now we're on to GI losses. So this may be through vomiting and diarrhea. So diarrhea produces a direct potassium loss. Vomiting works in a slightly different way. You do lose some potassium, but as you lose that blood volume through vomiting, you then go through aldosterone activation, and therefore that drives potassium loss through that mechanism. Remember, aldosterone causes potassium secretion. So that is driving that process. So vomiting is that direct loss, diarrhea is that direct potassium loss, whereas vomiting, you're getting some potassium loss, but that low blood volume activates the renin, angiotensin, aldosterone system, and aldosterone causes potassium to be lost. We've got renal losses, okay? So that'll be through magnesium deficiency and diuretics you might be thinking about. So diuretics obviously increase urinary loss, and potassium is one of those things that is lost in that urinary loss. So therefore, a medication history is quite useful. And magnesium is particularly important when potassium remains low despite replacement, because magnesium affects renal potassium channels, and in the deficiency, it allows more potassium to be lost from the kidneys into the urine. So just think, magnesium deficiency, more potassium is lost because you're altering the renal potassium channels. Redistribution. So now we're thinking, is potassium going into the cells? What drives potassium to go into the cells so your plasma levels or your blood levels of potassium look low? So that may be an alkalosis. In an alkalosis, we talked about it a second ago, hydrogen ions come out of the cells to try and increase the acid-base status in the blood. Potassium shifts into the cells in compensation, leading to that hypokalaemia. Insulin administration, remember, potassium shifts into cells, and beta-2 agonists, for example, someone on a nebulizer, beta-2 agonist nebulizer, potassium will shift into the cells as well, so significant levels of beta-2 agonists. So we've now done intake, we've done GI losses, we've done renal loss, we've done redistribution. What about the hormones? Well, we've talked about some of these already. You've got primary hyperaldosteronism, and that's you're thinking about cons with your increased renal excretion, and you're thinking about your Cushing syndrome. So Cushing is an excess of cortisol, and excess cortisol has mineralocorticoid effects. So it binds to the aldosterone receptor, in essence, when it's in excess. And so that leads to that renal potassium loss that we've already talked about. So just one little extra thing, because lots of people kind of forget this one. Hypomagnesemia, so low levels of magnesium in the blood, promote renal potassium wasting. And also, if you have low magnesium, it can make hypokalemia difficult to correct, because you might be taking more potassium or potassium supplements, but then you keep weeing it out again. So it makes it difficult to correct. So just have that in the back of your mind as well. What are some of the signs and symptoms? Well, it's important to remember that the hypokalemia causes hyperpolarization of cell membranes, and therefore that impairs normal nerve and muscle function. And some of the symptoms that it leads to are fatigue and lethargy. And it does that through that reduction in neuromuscular function. It also can cause muscle cramps. And again, that's down to that skeletal muscle dysfunction. You've got your muscle weakness down to impaired muscle excitability. And so this is showing us that the skeletal muscle effects, really, they range from fatigue and cramps to marked weakness that you can see in severe hypokalemia with your respiratory muscles in particular. You've also got your cardiac arrhythmias because you can't repolarize, you get abnormal transmission through the cardiac system, and polyuria as well because of the impaired renal concentrating ability. Rather than through an osmotic diuresis, you just can't concentrate quite as well. Thinking about an ECG, if you're that way inclined, so there are some common ECG changes that you might see in no particular order. You can see potentially flattened T waves. You might be seeing ST depressions. You see these prominent U waves that you don't usually see in health. So there are lots of potential changes that you see. And then, as we talked about, the symptom might be arrhythmias that can be seen in severe hypokalemia. So we're coming to how do you evaluate it. So we've kind of talked about all the causes, and that's what we're going to really go through. But there is a kind of a nice little logical stage that you can potentially go through as well. So you can go through your hypokalemia evaluation. So you've now identified a low potassium. The question isn't necessarily how to treat it. It's to say, which you will do, don't get me wrong, but it's why is it low? And in most cases, that diagnosis of the reason for it comes from a logical history or a bicarbonate, which will kind of help in thinking about an acid-base status, and your magnesium. So I think stage one, if you're to think about that, so we're just looking at number one up there, forget all the stuff that's coming down in front of you. You always want to start with a history before thinking about more tests. The most common causes of hypokalemia are normally apparent from the history. So if we're looking at this, is there an obvious cause? So is there a cause? Is there a history of vomiting or diarrhea? Are they on diuretics that can cause hypokalemia? Or are they taking laxatives that can lead to diarrhea? And if yes, then obviously you think about treating the cause and replace potassium as necessary. So someone might come in, a young woman goes to the GP with fatigue, muscle cramps, and a 2-month history of chronic laxative abuse. So obviously the key here is the 2-month history of laxative abuse, laxative use rather. So in this case, you've already found the most likely cause before you've gone anywhere else. Stage two, not all of this hypokalemia represents potassium loss from the body. Sometimes it's present, but it's been redistributed. And that's what we're thinking about in this case. So let's have a think about this patient, an 18-year-old man admitted to ED with DKA, diabetic ketoacidosis, develops weakness during treatment with intravenous insulin. So what's happening? He's developed weakness. He's being treated for insulin for his DKA. Remember, insulin activates the sodium-potassium ATPase that drives potassium into the cells and lowers the plasma potassium. So again, quite obvious when you know what the case is and what's happening. And in reality, someone being treated with intravenous insulin, you'll be well aware of keeping an eye on the potassium very, very carefully. But it's important to understand the principles behind it. Just remembering, of course, that the same thing happens with beta-2 agonists, such as salbutamol. So again, you're asking yourself, has potassium been lost, or has it simply moved? Those are the key things to be thinking. Stage three, so we still don't know what the answer is at this point. So if the history isn't obvious, bicarbonate often becomes the next clue. A high bicarbonate suggests metabolic alkalosis. So you may be thinking vomiting, diuretics, or primary aldosteronism, so cons. But when we look at this person, 43-year-old woman with resistant hypertension, complains of muscle weakness and frequent urination. So when hypokalemia and hypertension come together, primary hyperaldosteronism should immediately come to mind. So that's what we'd be thinking in this case. So I want you to think high bicarbonate, you're thinking vomiting, diuretics, low bicarbonate, diarrhea, and renal tubular acidosis. So you need to be thinking about the kidney function in that case. So key message, bicarbonate is helping narrowing the differential diagnosis very quickly. Finally, if all else fails, check the magnesium. So when potassium refuses to correct, magnesium deficiency is often the reason. And unless magnesium is replaced, potassium may continue to be lost in that urine. So 54-year-old man continues to experience muscle cramps despite potassium replacement therapy. You'd be thinking, is he still losing that potassium despite replacement therapy? Therefore, let's check the magnesium. Okay, so there's your kind of evaluation process. You can jump it around. You'll get different tidbits from the information that you'll get given if you do see patients. For example, if you are clinical or if you are a biomedical scientist or clinical biochemist, you won't necessarily be seeing the patients, but you will be getting information that will help in this whole evaluation process. So we're just going to have a little practice question for you. So read it, and I want you to then come up with the answer. Press pause. A 52-year-old woman presents with muscle cramps and fatigue. She has a history of hypertension and is taking a thiazide diuretic. Remembering, thiazide diuretics can lead to potassium loss. Her serum potassium remains low despite oral potassium replacement. She is normotensive, so blood pressure is normal, and she appears well. Serum potassium remains low despite that replacement. Oh, that's written there twice. So repeats blood show potassium low, sodium's okay, bicarbonate okay. Which additional blood test is most appropriate? Well, the key clue here is persistence despite that potassium replacement. And obviously I did it on purpose. I wrote that twice in the clue, so to make it a double clue. So remember, continuing thiazide treatment may contribute to ongoing renal loss, but in this case, magnesium should also be checked because magnesium depletion promotes renal potassium wasting. So therefore, what's the most appropriate test is serum magnesium. Remember, potassium replacement may be ineffective until any potential magnesium deficiency is addressed.